Welcome, good afternoon. Welcome to our Lunchtime Learning series with the Jim Pattison Clinic. Today we are going to be hearing from the Diabetes in Pregnancy Clinic, and we'll hand over to them in just a quick moment. But before we get started, as always, I'd like to acknowledge that we are gathered together today on the unceded and ancestral territories of the Coast Salish people. And here in Surrey-North Delta, we like to open up our sessions in a really good way and recognize that the land that we are on is the territory specifically known as Kwantlen, Semiahmoo, Tawasin, Haiti, Coquitlam, my mouth can't always navigate those ones, Quaykut, and the numerous Dolo First Nations. There's a couple of housekeeping items that we wanted to go over. Most of you have been in our sessions before, and so these are pretty familiar. If you're comfortable, we'd love to see you on camera. We are recording this session for posterity's sake and for our YouTube channel today. So if you're not comfortable either being recorded, you are welcome to keep your camera off. But we do ask you to turn your name, the name bar that you have, if it can say your name instead of iPhone, that would be lovely. We are going to be taking questions and answers at the end of the session, so please feel free to write your questions into the chat box as the session is going along, and we will get to your questions at the end. If you're not speaking, at the end we'll have a raise hand function, but if you aren't speaking, please make sure that you are muted. We want to make sure that our guest presenters today have the best audio for everyone. And then at the end, you'll see an evaluation link in the chat box, and that will be your ticket to get your CME credits for the afternoon. So our presenters for today are Tracy Messmer, who is the manager for clinical operations at the Regional Outpatient Perinatal Clinics, and Kristen Clausen, a registered nurse at the Diabetes and Pregnancy Program. So I'll hand it over to Tracy and Kristen. Welcome. We're happy to have you with us today.
Thank you for having us. We're thrilled to be invited to present. I just wanted to introduce not just my role, but the clinic to you all. So if you guys have referred to Jim Pattison Maternity Clinics under the umbrella that I help support, we have maternal fetal medicine, obstetrics, internal medicine, early pregnancy assessment clinic, outpatient fetal monitoring, nausea and vomiting in pregnancy, antepartum care at home care program. We have complex contraception. The old name used to be IUD, but we're just changing the name. And then we just have new medical genetics that just have come to Fraser Health, which we're in a pilot project with. BC Women's, we have a couple of resources within our clinic that if you're to refer your patients to, they might see our seamless perinatal social worker or see our complex outpatient pharmacist, Hillary Rowe. So, but of course, I'm introducing Diabetes and Pregnancy. That is one of our busiest clinics here. And so this is Kristen Clausen, one of our clinicians.
Thanks, Tracy. So hello, everyone. I'm Kristen. I am an RN and I work at the Diabetes and Pregnancy Clinic. So if we can just get the next slide. Today, I'll be reviewing the presentation, and the goal today would be to share with you more about what the Diabetes and Pregnancy Clinic offers. I want you to know how to make a referral to our clinic. I want to point out the common and possible referral mistakes that we see and how to avoid them. I'll go through what our referral triage process looks like. I'll also show you what it's like for the patient's experience as they flow through our clinic, both in the antepartum and postpartum phase. I'm going to key in a little bit about the gestational diabetes diagnostic criteria because that's a bit of a head scratcher. And then I'll also review some of our patient and provider resources along with our contact information and location. And I'll go to the next slide. Thank you. So the Diabetes and Pregnancy Clinic is often referred to as DAP, D-A-P, and we provide specialized care for people with diabetes, and they may have type 1, type 2, pre-diabetes, gestational diabetes, but they also have to be pregnant. And our team is made of endocrinologists, registered nurses, and registered dietitians. And just to point out, GDM or gestational diabetes is when someone has higher than normal blood sugar or blood glucose, and this occurs during pregnancy. And this occurs because the body's insulin is not working properly, so it's resistant or there's not enough being made. And high blood sugars can cause the baby to grow too large and have other health consequences. For those who have type 1 or type 2 diabetes, high blood sugars can increase their risk for miscarriage, having a baby born with malformations, or even a stillbirth. And so treatment is really important for this population group. It reduces the adverse pregnancy outcomes. And so a timely referral is really essential in this population. If we go to the next slide. And so making the referral. You can find the referral form for the Diabetes and Pregnancy Clinic on the Fraser Health Medical Staff website. You can also find it on Pathways. And just to note, if you can save the link to the form rather than downloading a form to your desktop, that way you'll be up to date using the most current version of the form, and that might help reduce delays in processing the referral. And we'll go to the next slide. So I'd like to point out some common referral mistakes. So when referring patients to the Diabetes and Pregnancy Clinic, please try to avoid the following pitfalls. So here's some common ones. The first being the wrong referral form. So it can be mixed up with the Outpatient Diabetes Health Center. That is not our clinic. We're the Diabetes and Pregnancy Clinic. So just use the correct form. And also make note of the location. So our clinic only offers services to those delivering at Peace Arch, Langley Memorial, or Surrey Memorial. So just make sure that you're sending it to the right Diabetes and Pregnancy Clinic. There are other ones available for Abbotsford, Burnaby, and RCH, but we only offer for those other 3 hospitals. And then to include all information. So one key piece can be the language. So please indicate if a patient requires an interpreter or if they have a preferred language. It's important to do this because we have resources available in multiple languages, and we provide the resources before the first appointment. So this is key to have it indicated on the referral. We also need to know the patient's due date. That's important because it might be an indicator for the urgency of the appointment. And also make note of any key comments that could indicate urgency. So common examples could be if there's macrosomia or an abdominal circumference over 90th percentile. And then please include all important records. So the lab results are key. We need to be able to see that there was an elevated 1 or 2 hour glucose tolerance test, or for those who have type 1 or type 2 diabetes, a current A1C lab result would be needed. We also need to have the antenatal records. And if you can note on the antenatal record, again, that delivery location, that's very important that we're seeing the right patients for the right location. And then finally, including any ultrasounds for the current pregnancy. Occasionally we receive ultrasounds for prior pregnancies, but those aren't necessary. So having a complete referral can really help with the timely processing. And we'll go to the next slide. So in terms of the triage process, when referrals are received at our clinic, we have a standardized process, and every referral is reviewed by a registered nurse or a registered dietitian. And so I'll just outline the flow. So we'll receive the referral from the unit clerk, and the unit clerk passes that on to the nurse or dietitian. And then the nurse or dietitian will triage the referral looking for the following information. So we'll determine the urgency and whether the patient has gestational, type 1 or type 2 diabetes. We're going to note if there's any missing key information like the ones I'd mentioned earlier. We'll also place a phone call and speak directly to anyone who has type 1 or type 2 diabetes, and we'll inform them of their blood sugar targets for the pregnancy as well as the frequency of blood sugar testing, so they can begin that immediately. And we'll also key in on factors that could indicate urgency. So that might mean if a person has type 1 or type 2 diabetes and they're in the first trimester, if there's someone with an A1C over 6.5%, if we see a fasting blood sugar over 6.0, or if any glucose tolerance value was over 14, or if we see an abdominal circumference over the 90th percentile. Those are some of the reasons we want to see a patient sooner. And once we code the referral, we provide this back to the unit clerk, and the unit clerk will then call the patient to book an appointment based on the triage result. We do have target wait times for when we're processing referrals. And so our target wait time between when we triage the referral to when the patient has their appointment, if it's coded as an urgent appointment, we would like to see them within 3 days. And if it's a regular intake appointment, it would be between 7 and 10 days. And I would like to note, unfortunately, even though these are our targets, we are not meeting them at present. So we are exceeding these. So just to point out our goal, although we're currently not there. And I'll go to the next slide. Now, when a patient's been referred to our clinic, we also have a standard process that they'll move through the clinic, through their pregnancy journey, all the way up through to postpartum. So in the antepartum phase, once the patient has been coded and the referral has been triaged, they get the appointment date and time from our unit clerk. If they have gestational diabetes or GDM, they're asked to come to our clinic in person or have someone else on their behalf come pick up a self-education package and a glucometer. And the self-education package should be reviewed by the patient immediately. And within that, it will guide them through initial planning and treatment. It includes a link to watch a class that we have available on YouTube, as well as begin blood sugar testing right away. So there is no delay with that. After that, they'll have an intake appointment, which is by phone, and this lasts 20 to 30 minutes. And during this time, the patient will talk to an RN or an RD, and they're going to help clarify some of that education package and provide further specific education support. We're going to assess the initial blood sugar levels as well as the patient's diet and activity. And following that, they'll have an in-person consult appointment. These often are between 1 and 2 hours long, depending on the patient and their urgency. But the patient will first meet with a nurse or a dietitian, and then they'll meet with the endocrinologist. And during the appointment, we provide further assessment and create a treatment plan specific to them. The doctor may order insulin, and if that's ordered, a separate appointment is made with the RN to teach the patient how to do this correctly. And then finally, after the consultation, the patient will receive ongoing phone appointments every 1 to 3 weeks until they deliver. So with the follow-up appointments, a patient may speak only with the endocrinologist for their appointment, or they may speak to a nurse or a dietitian along with the endocrinologist. So that means they may have 2 calls from 2 people on the team. We still consider that as one appointment because we come from a team approach. And then another note is for patients with type 1 or type 2 diabetes, we combine the initial intake and consult appointment all in one in person. And so that appointment can last up to 2 hours. Usually these types of patients will have more urgency. So I'll go to the next slide. So as the patient moves along and delivers, they reach postpartum. So those who have gestational diabetes, they will complete or should complete a 2-hour glucose tolerance test, which we like them to do 6 to 8 weeks postpartum. If they complete it in that time, we will follow up with the elevated results with a phone call with the endocrinologist. If they do not complete the lab work, we do eventually discharge everyone from our clinic after 3 months if we didn't receive labs. It is still appropriate if a patient would like to complete the 2-hour glucose tolerance test after the 3-month period, even up to 6 months postpartum, it is appropriate. However, we're just not able to maintain and keep them within our clinic. So we do discharge them to follow up with their family doctor. And then patients who have type 1 or type 2 diabetes will receive a postpartum phone appointment with the endocrinologist prior to their discharge from the clinic. I'll switch to the next slide. So I thought I would just briefly attend to the gestational diabetes diagnostic criteria. I think some people will, if they look at it in detail, it's a bit of a head scratcher. I'm just going to give a really brief overview of it. Now, there's two ways to diagnose for GDM, and both test types are seen in our clinic. So the Canadian Diabetes Guidelines has a preferred approach, and this is where we take an initial 50-gram glucose challenge test. And if it's abnormal, we follow it with a 75-gram oral glucose tolerance test. And then the diagnosis of GDM is made if even one glucose value is abnormal. So they're as listed. So fasting equal or greater to 5.3, the 1 hour equal or greater to 10.6, the 2 hour equal or greater to 9.0. If any of those are high, that's diagnostic for GDM and should be referred to our clinic. Now, the alternate approach is just streamlined to one step. So that is just going to a 75-gram oral glucose tolerance test. And the diagnosis of GDM can be made if one value is high, one or more. You'll see the values are slightly different for this test. So the fasting is equal or greater to 5.1, the 1 hour is equal or greater to 10.0, and the 2 hour is equal or greater to 8.5. So I don't want to go into the statistics behind the two different approaches and the nuancing of the slightly different abnormal values. But I think it's key to know that these two tests do exist. They're both recognized in the clinic. They're both recognized in Canada. And an abnormal result in either case is still an abnormal result. It still is classified as GDM, and we would like to see those patients. I also just want to point out that any patient who already is diagnosed with type 1 or type 2 diabetes, they do not complete this test. It is already recognized they are diagnosed with diabetes and do not need further diagnosis. And so if that could be avoided, we do occasionally see this occurring, which is unfortunate. And I'll go to the next slide. We offer a variety of resources, both for patients and providers. So in terms of the providers, the referring physician will receive a copy of the initial consult from the endocrinologist. And then the family physician will receive a postpartum summary letter. And this is after the patient delivers to remind the patient to complete their 2-hour glucose tolerance test about 6 to 8 weeks after the delivery. And we offer many patient resources. And so every patient will receive the following. They'll receive education booklets, food guides, access to educational videos, and glucometer education. Many of these are available in multiple languages. And just as a sneak peek or overview of some of the management that patients receive, well, everything will be tailored and individualized to them. Management of diabetes and pregnancy really falls under 3 key treatment areas. So we'll focus in on the diet, the type of food, and when they're eating that food. Activity level, which for pregnant women, we just encourage walking if they're safely able to, aiming for about half an hour a walk a day, and that can be split up to 10 minutes after each meal. And some patients will also need medication, and we use insulin and or metformin depending on the patient's needs. And these are safely used in pregnancy. So those are our focus areas for the treatment. Patients can also begin their diabetes care and treatment immediately because they're able to start their education and plan that's outlined in the diabetes self-education package. So in that regard, there is no delay in terms of when they can begin once they've been triaged and received into our clinic. And along with that, patients can call and they can talk to a nurse or a dietitian if they have questions or concerns in between appointments. And so we provide them with a direct extension to our nurse and RD lines. So that is also available in between appointments as things come up. And I'll go to the next slide. So as I think you may have already gathered, our clinic is located within Jim Pattison Outpatient Center. We're under the umbrella of maternity clinics, and you can find us on the 3rd floor under 3A. So if anyone's looking for a banner or a title of where to go, they're going to look for maternity clinics, not diabetes and pregnancy, because we fall under that. And then I've just provided our phone number with that direct extension. So 763-993 would bring you to our front desk. So if you have questions or concerns, feel free to reach out to us. And we're open Monday to Friday from 8:30 to 4. And next slide. Thank you for listening and for the time. And I think we switch over to questions now.
Thank you so much, Kristen. That was so informative. You covered a lot of ground in a short amount of time. Thank you very much. We have a busy chat box down here, so it sounds like everybody was really engaged. I'll start from the top. Dr. Rashmi Singhai asks, if a patient has abnormal fasting blood sugars months before pregnancy, and we do a gestational glucose tolerance test at about 12 weeks, would that potentially cause a miscarriage or malformations?
That is such an interesting question. I mean, of course, elevated blood sugars are not ideal, and we can't determine whether or not that would directly cause a miscarriage or malformation. Of course, we're wanting to avoid that. And in the case where a patient is already known to have elevated blood sugars, it would be suggested perhaps do a fasting blood sugar and A1C if those are elevated. Now we're not providing a glucose load, and we would have that referral triaged. They could come sooner to the clinic and avoid that the GTT.
Thank you so much.
Mhm.
All right, we have another question here from one of our MOAs, Juanita Peterson. She's wondering, is the delayed wait time based on incomplete referrals or just very busy?
Oh, thanks for that question, Juanita. It is a mix of both. I would say lately there's been a lot of changes within the clinic, and with that, our wait list has been growing. We do typically see a growing wait list through the summer months, just with more holiday time by the people who work in our clinic. But yeah, it is a little bit of both.
Thanks so much. All right, Dr. Barry Lamb had a question. Can you refer a type 2 diabetic as soon as they are pregnant, even before their prenatal form and ultrasound are completed?
Yes, please. Yeah, as soon as you discover pregnancy, please refer them over. We're happy to begin with them. And then as the other information is available, it's nice if we can be updated with that. But a referral just with the most recent A1C and an idea of their due date, we can work with that.
Awesome. And then Juanita had another question here. She's wondering, do you arrange the follow-up lab, or is it the GP's responsibility?
Yeah, great question. So everyone who has gestational diabetes would automatically receive lab requisition for the 2-hour glucose tolerance test to be done postpartum. On a similar note, everyone is also provided with a prescription to have their test strips and lancets for the testing through the whole pregnancy. So that prescription is also automatically provided.
Awesome. Dr. Maninder Singh is wondering, when do you advise a GTT if a mother is pre-diabetic prior to conceiving?
Yeah, that's a great question. So it would be advised for conception planning, just to rule out whether or not she's like switching over into type 2, for example. If it is already showing an elevation, we can receive her into our clinic once she becomes pregnant. In the past, we did provide preconceptual care, but we no longer do that. But once she does achieve pregnancy, you can refer her to us along with the lab results.
Thank you. And Dr. Helen Jin is wondering, GDM, GTT abnormal values cut off, 2 different ones on the slide. Which one is reported at the hospital lab/life lab?
I would have to double check to compare hospital versus life labs. I don't have that top of mind. And I'm not certain if they're different between hospital and life labs, but I can get back to you.
Thank you. And another question here from Prabjot Kaur, who is one of our MOAs. What are the chances of baby getting diabetes from the mother if it's just gestational diabetes?
Okay, yeah. So we don't anticipate the baby having diabetes as a consequence of the mom having GDM. A baby has high risk of growth, so growing larger than expected, which could impact delivery, and then having hypoglycemia upon delivery. So those are the key risks for baby. However, if baby was growing larger than it was meant to be, that can continue through childhood. And so there can be higher risk for obesity, and that can actually lead to higher risk for prediabetes. There also may be that genetic component from mom to baby, but a baby won't be born or anticipated to have diabetes directly, but could have sort of more lifelong higher risk of diabetes. I hope that answers the question.
Thank you, Kristen. And then last question from another MOA, Gagan Niger. Are you able to take patients from all over the Lower Mainland, or is this just for Surrey?
Yeah, we will see patients who are delivering in Langley, Peace Arch, or Surrey Memorial, just those three hospitals. If they're delivering at a different hospital, even if, say, they live in Surrey, but they're delivering elsewhere, then they would be referred to a diabetes and pregnancy clinic for the delivery hospital.
Awesome. And I don't see anyone with their hands up, but before we wrap, does anyone have any additional questions that they would like to ask either Kristen or Tracy?
I think I'll follow up back to the one question just I was answering quickly, but in terms of someone with prediabetes, I just would like to make note too that if they have prediabetes, not type 2, you can provide the 2-hour glucose tolerance test in the first trimester if you don't have indication that they're type 2, that they're just pre. So I hope that adds another layer to the question. I'm sorry I didn't get that right away.
That's great. Thank you. So we are perfectly at time. Thank you so much, Tracy and Kristen. It was a valuable session, and to the MOAs and family physicians who attended, thanks for your great questions. The evaluation link has been posted in the chat, so we invite you to please complete that. We will circulate the Q&A portion and the slide deck and the link to the video recording shortly. We hope you all have the most fantastic rest of the day and look forward to seeing you for our next series in a couple of months' time. Thank you so much, everyone.
Thanks, everyone.